Everyone. We're back today with Doctor's Corner. We have Dr. Chloe Ramon with us today, and we're going to talk about ultrasounds and sonohystograms. She's going to give us an overview of different areas and why a patient would need to have an ultrasound throughout their fertility journey. Nice to have you on, Chloe.
Hi, Melissa. Thank you for having me on.
Oh, thanks for coming on. So I just have a few questions for you, so we'll get into it. So what type of ultrasounds are completed throughout a patient journey?
So typically we start with baseline ultrasound, so a baseline pelvic ultrasound to evaluate sort of two categories of things. So on the ovarian side and on the uterine side. So on the ovary side, we want to see the ovarian reserve. So that's measured through the atrial follicular count, or AFC. Typically, that ultrasound is done early in the cycle between day 2 and day 5 on average. So we literally want to count the follicles that we see, and that will give us an indication of the number of follicles that the patient has each month going in their pool of follicles each month going forward. And on the uterine side, we want to see any anomalies of shape, any fibroids, any growths, anything at all that can be seen on the pelvic ultrasound. And same for the ovarian side. I mentioned looking at it from an ovarian reserve perspective, but you can also see any pathology. So if there's a cyst, a growth, anything there, we would be able to see it at that time as well. So that's the baseline ultrasound that we do. Then there is a sonohysterogram. So that is typically done in the second week of the cycle, ideally between day 7 and day 10 or 11, ideally before ovulation. And that ultrasound is particular because we want to inject fluid inside the uterus and through the fallopian tubes. And we want to evaluate two things. So here we do it with saline. So we inject saline into the uterus by installing a little catheter at the cervix. So with a speculum, we install a catheter and then we push saline into the uterus. And at the same time, we're looking with the ultrasound probe. And what we want to see in the uterus is the inside of the cavity, and we want to see the shape. Why do we want to see the shape? Well, some people can be born with uterine abnormalities, such as like a septum or any change in normal shape. Or there can be acquired things like a polyp or a fibroid that we would be able to see with this test if it's touching the inside of the cavity. And then we inject a contrast liquid that allows us to follow the trajectory through the tubes. So that allows us to see if the tubes are open or patent. If the fluid goes up and leaks out of the end of the tubes, then we're able to confirm that they are open. That's commonly called the sono, but it's a sonohysterogram. So those are the big two ultrasonic tests that we do for patients early in the fertility journey.
Okay, great. No, that was a great explanation. Thank you for that. So when you look at the fertility workup and the pre-pregnancy and post-pregnancy ultrasounds, what are the differences?
So pre-pregnancy would be sort of the ones that I just described, really to evaluate the anatomy and the ovarian reserve and any pathologies. During pregnancy, there's different ultrasounds at different times of the pregnancy. So early on, it would be viability ultrasound, also done. They're also pelvic, and they're usually transvaginal and abdominal, where we look at the embryo or fetus, depending on the stage that we're doing it, to see if it's viable. So we measure the size, we see if there's a heartbeat, and we see if it's implanted in the right area, and if there's any bleed, any sort of abnormalities in the development. And those are done typically around 7 weeks, our first one, and then 2 weeks later, 9 weeks. So those two confirm viability, or if the pregnancy is alive and progressing properly. And then we go on to a 12-week ultrasound which is where we measure the nuchal fold, or the space behind the neck of the baby, and so on. As the pregnancy progresses, there's a morphology or anatomy ultrasound around 20 weeks, and so on and so forth. You mentioned post-pregnancy. There's not usually a prescribed ultrasound post-pregnancy unless we're worried about retained products of conception, or retained placenta, or anything that may have gone wrong in the pregnancy or delivery that we expect to find something on the ultrasound, but there's not a dictated ultrasound for post.
Okay, great. That was good. Just wondering, going back to the sonohysterogram. So can you just explain what that is again, and what does this device detect?
Okay, so a lot of times patients will read up on it and be a little nervous and read that it causes a lot of cramping. It can cause cramping. It usually does cause at least a little bit, but it's similar to period cramp. And we advise patients to take Advil or Tylenol before the test, and that usually helps. The beginning feels like a gynecological exam with a speculum, and we insert a catheter that has a little balloon at the end. We insert it in the cervix. We blow up the balloon so that the catheter stays, remove the speculum, and we put the ultrasound probe vaginally, and then we inject saline. So as I was saying before, as we inject, we can see the image, we can see the uterus filling up with this fluid, and that will allow us to see the contour of the inside of the cavity. So when you do a regular pelvic ultrasound, you do see the uterus as well, but you don't see the inside because it's not filled with fluid. So the uterus the two sides are stuck to each other. Whereas when you do the sono and you fill it with fluid, it fills up and you can see the inside. So it allows us, like I was saying, to see the contour, to see if there's a normal shape, and to see if there's any growths. And then once we insert, we change from a saline injection to a contrast, then we can look and see if the tubes are open, or if if you have a hydrosalpinx, which is tubes filled with fluid, or if they're blocked, or if there's anything off with them. So those are the things that you would see, and that's the way that it is performed.
Okay, why is an ultrasound necessary?
So, given the nature of the different problems that can cause infertility, on the female side, generally there are three parts that can be malfunctioning, if you will, either on the ovarian side, so the ovarian reserve, on the uterine side, so in terms of the implantation, and then the tubes where the sperm and egg meet. So it's really through ultrasonography, some blood tests as well, but mostly through ultrasonography that we can see if these areas are functioning properly, or if we have normal findings. So as I said, the pelvic ultrasound allows us to visualize the ovaries and see if there's any cysts or anything abnormal there, and also the ovarian reserve through looking at the number of follicles. The tubes, one of the only ways to see if they're open is through a hysterosonography. There are also other ways. You can see it surgically, and you can also see through a hysterosalpingography. So that's so again, these are other ways that you can visualize it, but ultrasound is one of those ways. And thirdly, we were talking about implantation. So again, seeing the inside of the cavity, that it has a normal shape and that there's no growths or anything inside. Again, ultrasound is one of the ways to see this.
Okay, great. So when you were talking about follow-up, with the follow-up process, what would that be after an ultrasound is performed?
So after a pelvic ultrasound or after a baseline ultrasound, typically we don't see the patients right away the same day, like they have the ultrasound and they go home, because it's part of a whole workup that we've prescribed. So they usually will complete everything that we've prescribed. So if there's blood work to be done or the sono, they'll go ahead and do everything, and then we'll follow up and go over all the results. And what we would communicate to them is what was seen. So in terms of their ovarian reserve, is it average? Is it low? Is it high? Do we suspect polycystic ovaries? Did we see a cyst? Did we see a fibroid? Whatever it is that we found, but it would be at a later date. It's not typically on the same day as the ultrasound is performed, but they would basically have answers about the findings and what that means for their fertility chances and their success rates and whatnot, and what treatment we're recommending. As far as the sono, if we perform it, so if I'm there and I'm doing it, I will communicate the results to the patient right away, because it's happening live, so I know I can see and I can communicate the results right away. So if there's obviously a longer discussion to be had because there are some findings that require surgery or some type of intervention, we don't cover everything at that time, but I can at least tell them, your tubes are open, the cavity is normal, just a general overview of the findings. And then at the real follow-up ultrasound, we can go over the management and what comes next.
That's a perfect overview. Thank you so much,
You're welcome.
Dr. Roman. Yes, so that's it today for Doctor's Corner, but thanks for coming on.
Thank you very much. Bye-bye.
Bye.